right? They were pertaining to diagnosing and managing hepatocellular carcinoma. So the focus is on HCC itself. Before we delve into the imaging, I would like to just kind of briefly go over what causes HCC and why is it important for us as radiologists to identify this disease. So anything that we look at, I try to approach it like, why are we doing this? Should we even do this test? And how do we do it? Because the technique, especially in MRI, as you all know, is extremely important, more so than CT, which is more standardized protocols. And what is it that they, meaning clinicians, want to know from us? What information? We don't want to give them unnecessary information, but you want to give them critical information in a substance form. And if we question ourselves this, I think what we put out for them is going to be more useful and more succinct. So just to kind of review, liver cancer is not that uncommon. It's the fourth most cancer in the world, and it is increasing every decade because although the HCV infection has stabilized in the Western countries, the HCC development has a lead time of 10 to 20 years, and so the number of cases of HCC incidence is increasing over time. Now, the risk factors for HCC, as you all know, is chronic hepatitis from either HCV or HBV infections, cirrhosis due to other causes, and this is the WHO map of endemic areas all over the world. Africa being the most endemic, and also East Asia, Southeast, like China, and those countries, and India falls somewhere in between. It is 1 to 2% or considered HCV carriers. And in India, I think these are like the problem areas. And this is something I pulled out a while ago regarding hepatitis in India. I'm not going to belabor on this. Basically, what they have recognized, as I was telling you before, even in 2014, the newsletter from the National Center for Disease Control in India started an initiative where they want to collect data in order to standardize how to, identify these patients and who should be screened for HCC regarding the patients who are HCV carriers and who have HCV infection. So there are about 18 million projected in India right now to be HCV carriers. So like when you look at these numbers, they're not really that small, and with a lead time of 10 to 20 years, you can see how many of them, about 80% of these people who are infected eventually will get chronic hepatitis, and out of that 10 to 20% are going to get cirrhosis, and out of that, eventually quite a few of them will develop liver cancer. HBV is also quite a problem and endemic disease in India, and there's also 10 to 15 to 25% lifetime risk of death from chronic hepatitis and HCC. So, considering all this, HCC is not something that only tertiary centers will see. All people, prior radiologists practicing here, are going to come across hepatocellular carcinoma, and you may want to be able to recognize them, in a general like pool of cases that you see. And basically, the things that I want to show are like how do you kind of parse out the nitty-gritty and how do you identify the common lesions from non-common ones and what are the ones that should raise red flags for you as to, that this could be HCC. So we're going to kind of skip over this since we already talked about. Now, in terms of rationale, now why screen this, right? Like, so, okay, you identify a population at risk, and if you screen those patients, there should be some benefit. If you screen them and find disease early, their morbidity and mortality should decrease. Like if it is a very aggressive cancer, for example, it doesn't matter if you recognize today and they're going to die in 6 months. If the biologic lifespan of that is like that, then there's no point in screening people. So actually the largest data came from China by Zhang et al. It was in 2004. They said they did a randomized trial about 20,000 patients in Shanghai. About 10,000 patients they screened and 10,000 were not screened with AFP and ultrasound. And they found that among the screened population, since they found smaller, earlier cancers, the mortality reduction was as much as 37%. So, so that's a very strong argument for screening patients for HCC, especially the ones that are at risk that we're talking about. And as we know, the treatment for advanced HCC is dismal, right? Like the survival rates are dismal. So you want to catch them early if you can. So these are the various, this is the American Association of Liver Disease and ESO, the European counterpart. They have guidelines for screening for patients at risk, and right now the guidelines still remains AFP and ultrasound, and so you must be wondering, like, what is she talking about? Where does MRI come in? But most of the people have switched into CT and MR imaging for patients at risk because of this problem. Patients with cirrhosis or AFP of more than 20 nanograms, CT and MRI is more sensitive because, as you know, like with a background of diseased liver, to pick up small lesions on ultrasound would be very challenging, especially small ones that are like a centimeter or less than 2 centimeters. And also, depending on patient body habit, as is well known, ultrasound could miss a lot of smaller lesions. The other thing, other factor that it is very important for us as radiologists to recognize HCC and diagnose is the UNOSIS, United Network for Organ Sharing. Their policy is what is followed by all transplant centers in U.S. So the UNOS policy, they no longer, this is very important for us for practicing there. They don't require histologic confirmation of HCC for bumping their patients up and down the list of the transplant list. If we say the lesion has typical characteristics of HCC, it is as good as a biopsy. So nobody biopsies these lesions. So they hold your feet to the fire. Transplant surgeons want you to tell them, is it or is it not? So because there is no cop-out for us, right? So you have to commit one way or another. So that also makes it imperative for us to be able to recognize these lesions as well as we can. Okay. And these are the various transplant societies. So they, knowing how important imaging is, so they want to standardize how we image these patients, how we report them. So they sponsored a consensus conference on HCC in 2008, and one of the working groups specifically looked at developing more specific imaging criteria. So in the all tertiary care centers, we have to follow this criteria guidelines developed by this committee, which is like you cannot, for example, just scan a liver on a 0.3 or a 0.5 Tesla magnet. You cannot just scan a liver like and do like a 7 millimeter slide. So they even do very specific as to the requirements of what sequences, what, because there were radiologists involved also in this. So these are some things that, you know, even before you start looking at the cases, you want to make sure you have, you know, everything that you want the way you want, because you are trying to find disease on top of disease, which is very difficult. And this is an effort to reduce the false positive rates and, you know, standardizing report and so forth. Okay, I'm just going to skip over this. Like I said, you know, these are the things that they came up with, this, you know, to make it as standardized and as foolproof as possible. And as you can see, that they were very specific, and, you know, even in terms of the injection rate, and you know, the slice thickness and what phases we should do, how much we should wait, and all these things. So these were the things, like I said, you know, when I started practicing, none of this was there. So we kind of learned by trial and error and trying to present abstracts, and this is what we were doing already. So this is not something, and now it is actually most of us do less than 5 millimeter. Usually it's about 3 millimeter slices. So like I said, you know, at least you need 1.5 Tesla magnet for liver imaging, because you need a high field magnet. So coming to the protocol, I mean, you all are familiar with different protocols. I'm just going to say that you want in-phase, out-of-phase, some kind of T2-weighted imaging before. Very important to have T2-weighted imaging. Important to have diffusion-weighted imaging, because you want every arsenal in your armamentarium to diagnose, because if one doesn't work, maybe the other thing will work. And the pre and post, you know, gradient, fast gradient echo. Lava is very typical for GE. Each machine has their own lingo. Siemens has their own. Phoenix has it. Siemens calls it. But basically, it's 3D fast gradient echo images, dynamic images, pre and post, arterial phase, and then a portal venous phase, 60 to 70 seconds. And in Einstein, like we had originally picked 7-minute delay. But anything more than 2 minutes is considered as the interstitial or delayed phase is good enough. So most people do about 5-minute delay. So this usually diffusion-weighted images, typically for body imaging, liver imaging specifically, usually everyone has a B0, but somewhere between B500 to B800 is what we do, and some places do both. We use both B500 and B800. Okay, in and out of phase images, very important. Can't skip, and this whole protocol can be done in 30 minutes. As you know, sick patients cannot lay on the table forever, so you also have to be cognizant of that. And most of the high field magnets, we can get all these images in less than half an hour, in at least half an hour, if not less. And then pre-contrast, arterial phase, portal venous phase, and we also, while waiting between the portal venous phase and the delayed 5-minute image, we also started doing corona, because we realized, like, you know, how your eyes don't pick up certain things, like we missed a few left lobe lesions for whatever reason. So this was another plane of, like, while we were waiting, we started doing corona images also. And these are all breath-hold images, and usually takes about 15 to 20 seconds. So now, coming to, so once you have these images the way you want, like what do you want to describe in your report? So what are the things you need to look at? The morphology of the liver itself, the size, nodularity, lesions, and lesions describe them by segments, like so that the surgeons know, like which segment the lesion is in. And you not only describe the size of the lesion, the location, and the enhancement pattern, and also what it does in diffuse. You have done diffusion-rated imaging, whether it has restricted diffusion, what it does in T2 rated imaging. So you want to have all of that in the report and give image numbers if possible, because these patients are repeat customers, and so the next person reading doesn't have to go over 100 images to find the one pixel that you described. And what's with the spleen, if there's splenomegaly and vessels, especially the portal vessels, where is this collaterals, whether there are any portal thrombi, of course, ascites and lymph nodes and other stuff. Now, this is how our reporting evolved. So this is how our initial reports used to look like. Scattered hyperenhancing lesions demonstrated during arterial phase may represent scattered foci, like saying like it may be this or that. And this one here says arterial phase enhancement of these lesions is of concern, but how sure are we? And again, this one says suspicious for HCC, but are grossly unchanged from prior exam, like 4 months ago. So what does this transplant surgeon do with this? They're like, what do you do with it? Tell me whether it is or isn't. So, over time, our reporting also evolved, and we also found by experience, and we also, that other groups also came up with the same finding that many lesions that were very tiny foci arterial enhancements were transient, and less than 1 centimeter lesions were not reliable, so you should not call every lesion every focus that we see on the arterial phase as HCC. You should also take other things into consideration. So that's how our report was, and then eventually we evolved into this. So no lesions, that's easy enough. And then category 2 was benign findings, whether it's a fatty liver or a cirrhotic liver or a nodular liver, but no HCC. Or incidental findings, for example, liver cysts and angiomas being common, you can see that in these disease livers also. And indeterminate lesion, no matter how much you try, sometimes you just can't tell, especially the small ones. And suspicious for HCC or malignancy, we were almost there, but it did not have every single characteristic that we would like to see for HCC. And then 5 was like a no-brainer, like, it is definitely HCC. So basically what they do now is they take category 1, we call them category 4 or 5. They upgrade or downgrade them on the transplant list. For example, if there are more than 3 lesions, more than 3 centimeters in size, they're not transplantable. Or for example, if they have a 2 centimeter lesion and 2 centimeter and above, they go up the list. So based on our categorization, the transplant surgeons can place their patients where it is fit. So, so this is how our reports started looking like, our structured reports that we worked on, and we would say that what category it is. For example, here I don't think you can see from there. No lesion suspicious for HCC. Category 2 lesions including 2 hemangiomas in segment 7, a 3.9 centimeter cyst in the caudate lobe, which appears to have fine septations, and at least 2 tiny cysts in the left lobe of the liver hepatoma. Very specific. So there is no kind of, as much as possible. Obviously, when you say category 3, you know that you have to follow that lesion and as to what it is going to turn out to be. So the OPTN classification somewhat similar. So everyone has come up with categorization of liver lesions. So I'm just going to skip over. And LIDAC is devised by the American College of Radiology for just like for mammography, BIRADS, and this is what most people use, which is almost identical to what we had started using in 2008, 2009. And now let's start looking at some of these, so-called lesions. So this is, as you can see, a nodular cirrhotic liver. T1 weighted image, pre-contrast, hypointense on T1, MIV, hyperintense on T2. And there were quite a few years ago, there were few papers which showed that if a lesion is hyperintense, and how do you differentiate between cirrhotic nodules versus HCC? And once the lesion is bright on T2, we have to be very suspicious. Bright means not as bright as, usually they're not as bright as hemangiomas, but if it is hyperintense on T2, you have to look at those nodules very carefully. And this is the diffusion weighted image showing the restricted diffusion. And arterial phase, you can see the bolus in the hepatic artery and the aorta. There is definitely some enhancement, and the delayed, I don't know if you can see, there is some washout. And another criteria for calling HCC is visible growth. Obviously, like cirrhotic nodules typically do not get larger in size. So 6 months back, this lesion definitely looks smaller than what it looks like now. So that's also, so this is something you would call a category 5 or a typical HCC, right? So if everything is like that, then we don't have to do all this and jump through all these hoops. However, again, a very small lesion can also have typical characteristics. This is again a T1 hypointense, T2 hyperintense lesion showing restricted diffusion. So no matter how small it is, if it shows typical characteristics, you're kind of done, like it's enhancing and it's washing out. HCC, next case. What about this one here? So there is a nodule which is brighter than rest of the liver even before we give contrast. Now, did it get any brighter? So this is where you have to do subtraction, right? And subtraction is great as long as the patient takes breath the same way and there is no misregistration. So when you do subtractions, you have to make sure that you're really it is the same slice you're subtracting. So typically, if the patients are cooperative and they follow instructions, it works out. So there is some enhancement on the subtraction images. And typically, most of the centers, they automatically subtract everything. Like we used to selectively do subtractions because otherwise there would be 1,500 images. So anyway, subtraction is helpful whenever you have a hyper-intense lesion on T1 before giving contrast. And this one is a little different. This is a delayed 20-minute image. If you notice, the liver is much brighter, right? So this is US. This is a hepatocellular, hepatocellular specific agent that many people are using for diagnosing liver lesions. I am not a great fan of that to diagnose HCC yet. Like the jury is still out there. A lot of centers have switched to what do you call these hepatocellular specific agents. But I feel that the bulk of experience has been with the extracellular agents. We still don't know how these are going to pan out with smaller lesions. So there are articles coming every few months as to whether we should use it or not. So like I'll let you look through those. But you will see some of those also. Hepatocellular agents, HCC, is supposed to not behave like normal, liver cells, and therefore it is going to wash out. But anything that is not normal liver cells is going to wash out. So that is something that you have to bear in mind. This is another lesion, again, hyperintense on T2 enhancing and washing out with, a capsule, pseudo capsule. And this is a patient, and then same patient, notice that there is thrombus in the right portal vein, and the main portal vein looks kind of, these are just collateral. So there is portal vein thrombus. It's very important, especially when you see large lesions, to follow and see the tumor is going, that they grow right into the hepatic veins. IVC will grow right into the porta. So you want to look at the vessels carefully. This was kind of a bizarre case. A patient who did not have any liver disease had a enhancing large lesion. Initially thought as FNH, but it does not, notice that it does not behave like a typical FNH. It enhances heterogeneously and washes out. FNHs they follow liver signal in all cases. They don't completely wash out. And actually, in patients where you're suspecting FNH, it is useful to use. That's the only time that I feel the hepatocellular specific agents are useful. They retain contrast, the reason being that there are no biliary canaliculi, so they take up the agent and then they retain it. So they actually, over time, when you do the delayed, the hepatocellular agent, you do a 15 to 20 minute delay. So they are actually brighter, if not, at least they're the same brightness as the rest of the liver are factored into the brighter. So if they retain the hepatocellular specific agent, then most likely they are focal nodular hyperplasia or they are benign lesion. Now this is also another bizarre case. This is where you have to have everything that you have at your disposal. You can see T2 weighted image, again, a lobulated liver, consistent with cirrhosis, some feed fluid. Several lesions, 1, 2, and 3. These two are minimally hyperintense on T2. This is much brighter than the other two lesions. And then this is the pre-contrast T1 weighted gradient echo image. You can see that this is a tad bit brighter than the background, these two lesions here, and the T2 hyperintense lesion is hypointense, clearly hypointense. Now with contrast, you can kind of surmise whatever you like, but it does enhance. I mean, definitely there is some enhancement. This one also may be some enhancement, and they definitely wash out, right? Over time, they definitely wash out. So these turned out to be hepatocellular carcinomas, So like this is a great example of, so these were initially called FNHs and hemangiomas elsewhere. And look what happened to these lesions. This was in '07, and then this was 3 months later. They all grew. Hemangiomas don't grow, right? So so don't be carried away by just one sequence or one feature. Look at all the features, and that's the reason you want multiple, all these sequences at your disposal. And if somebody, like I know that you are not ones who dictate as to what is done, but for, like they showed me one case, which is what prompted me to do this talk, um, from somewhere, where they had sent only the pre and post contrast images. So you can always ask them, is this all you have, or did you do any other T2 or diffusion-mated images? Maybe they did, and maybe they thought it's not important to send it to you. Who knows, right? So just to keep that in mind, especially when you're reading these kind of tricky cases. This is another patient whose AFP was through the roof, and T2 weighted image showing very ill-defined heterogeneous liver, and maybe there's a lesion, maybe there's not. And then pre-contrast images, again, patchy areas of lower signal intensity, but then the whole liver is heterogeneous. And arterial phase, again, who knows, right? But look at the delayed image. Look what's going on here. All different areas of washout, and look at where the portal vein should be. Never followed the signal of vessels. Never filled up, and it's stopped in with tumor thrombus. So this is basically infiltrative HCC. So this is something that you want to keep in mind, especially if the AFP is done. So that's why it's helpful for you to know everything that you can know about the patient. If you said the patient, patient's AFP was 1,000, like you would be looking at this more carefully. But anyway, there is tumor thrombus in the portal vein that should kind of tip you off as to something bad is happening. Now, is this also an infiltrative HCC? So that was the question when we saw the CP. Who knows? This could be very well be an infiltrative HCC, although on the arterial phase also it looks kind of low in attenuation, but very well could be if the patient has a tip shunt. And the in-phase, out-of-phase images, see that the very same areas drop out in signal. So, and on the pre and post contrast images, there's really no enhancement, right? And also the other tip off is you look at these vessels. The vessels are not displaced. Usually tumor displaces and distorts vessels, and that's something that you want to keep in mind whenever you see something bizarre. Is it doing anything to the normal course of the vessels? So all this was you can get periportal fibrosis, you can get periportal fat infiltration, diseased liver. So this was just periportal fat infiltration. And this was actually somebody who worked in radiology department and had hepatitis and had liver transplant eventually. And she used to come for regular screening. And you see this low signal intensity area, which is mildly hyperintense on T2. And again, this was in about a year ago, a smaller area next to the portal vein here on CT. And what happens with the post-contrast images? Post-contrast images, again, kind of low on T1, which was seen already. and immediate post-contrast. Again, hard to say, not much of an enhancement, but it retains contrast on the delayed images. It's kind of opposite of what you want to, what you want to see in HCC. And this is how it was on on the subsequent CT scan. As you can see, it really didn't do anything to the vessels. It didn't move. Normal vessels didn't move anywhere. So what it was periportal fibrosis. So this was something that we scratched our heads, and not everyone agreed that not everyone was comfortable calling it periportal fibrosis and leave it at that. But we did think about it, and we said, let's follow up, and we also want to see if the ASPs are raising. But anyway, just to show you all these nuances that can, all these other disease processes that can occur and kind of throw you off. So at least when you're aware of it and you look for the fibrosis usually enhances slowly. So that's another thing, you want to think about when you see that delayed enhancement that is retained. And this is the reason I like the routine extracellular gadolinium, because we know over several years of experience how these things behave. And if everything goes and sits in the liver, then it would be very problematic. Okay, what about other pitfalls? Focal fibrosis, again, low on T1, okay, not much of an enhancement, and it can retain contrast. And the other thing is there is a retraction. Any tumor space occupying lesion, as you know, will actually bulge out the margins, whereas focal fibrosis, you will have retraction of the liver contour. Again, contrast, you're not going to see much of contrast enhancement early on. And you're all familiar with these wedge-shaped transient areas of enhancement, and just seen in the arterial phase, and you call it TAD on CT and SID on transient hepatic intensity differences. And if they're typically wedge-shaped and peripheral, you don't, usually they don't cause much problem. And this is same patient 8 months later, they come and go. So again, the thing to see is, see what is happening around the vessels, and if any of the normal architecture is distorted, which it is not. Again, these little, like we were talking about, little tiny foci of hyperenhancement in the arterial phase can be sometimes, bothersome when you're initially looking at them. Haven't looked at enough of these. If they're big enough, you may even want to follow up with a short-term follow-up. But this is less than 1 centimeter. Their margins are always kind of fuzzy. They're not like the GL lesions you saw with well-defined margins. So you see these foci, we call it non-specific foci of hyperenhancement, some kind of vascular shunting or whatnot. And you can also get shunts and varices within the liver, especially many of these patients have had biopsies. It could be iatrogenic or it could be spontaneous. So but most of these follow the signal of the vessels. They follow the same signal. So this was one of those, like a portal varix. And you can see that it is, it always follows the vascular signal, and also helps. And for us, we found that the coronals also helped us to kind of give one more perspective of the problematic cases, and it really does help sometimes. And common lesions also can occur in these diseased livers, right? Hemangiomas. So you apply the same, rules that you apply to cause hemangiomas. The T1 low signal, as bright as a light bulb on T2. And of course, you're going to follow all these. And they should remain, typically, they should remain stable. And smaller hemangiomas, they can enhance quickly, the whole thing can fill up, but that's okay. But as long as they stay bright on the delayed images and they are very hyperintense on T2, like you saw, if they, if they fulfill all the criteria, imaging criteria for hemangioma on MRI, you can still call them hemangiomas. The problem becomes when they don't. And, the one thing I would say is I would not call any lesion an atypical hemangioma in a patient who has cirrhosis. If it looks atypical, I would say this could represent HCC. That's like they said, first 6 diagnoses of a liver lesion in a patient with cirrhosis should be HCC. So that's something to keep in mind. Now, these patients are, now that you're finding all these small lesions, these patients are being treated, right? I mean, they're done as a stopgap measure while they're awaiting transplant or to downgrade them. They're doing ablations, chemoembolizations, and so it's important for us to know how the treated lesions look like, and then we have to look for new lesions, the patients with cirrhosis and treated lesions. So we need to know how they look, the ablated lesions. This is an example of an ablated, radioablated lesion. You typically, at least almost up to a year, at least for 6 months, they're brighter on T1. So it's important to know for you, like, if the patient has had any prior local treatments like ablation, space, whatnot. And typically on T2, it is not hyperintense, although it can be heterogeneous. Usually it's not hyperintense. And there should not be, if it is successfully treated, it should not have any enhancement. And you can have a rim enhancement in the delayed images. And over time, they should decrease in size, right? Then any successful ablation, it should decrease in size. So that's a good outcome. Now, this was, as you know, dome lesions are very, the approach is hard for them for the interventionalists to ablate. They tried. This was the lesion, right? So post-ablated images, pre and post, the lesion was still further posterior. They didn't even touch the lesion. So we told them, like, the lesion is still there, and next time they taste the lesion. And so this is post-taste. You see that, again, you apply the same rules. You don't want to see a hyperenhancing lesion if it is successfully treated on arterial case. Now, what if it is partially treated? All of this happens. I mean, these are all cases we actually solved. And so this was a post-taste, and they taste them multiple times. So, it can get very hairy sometimes. And many of these patients have more than one lesion. So this can be very time consuming sometimes. So T2, again, you don't want to see, I don't know if it projects. Okay, we are almost coming to the end. Should we stop, or there's just a couple of more pages? Okay. So if you turn that light down, maybe you will see very minimal hyperintensity of T2 here, if you can appreciate. This is the treated cavity, right? Like, I mean, there's really nothing. But whereas here you can see compared to the background liver, there is a suggestion of mild hyperintensity on T2. And this is the gradient echo T1 weighted image pre-contrast. And post-contrast, you can see that there is kind of a semicircular area of arterial enhancement, which washes out. So apply the same criteria. So we said that, there is still some residual tumor. So they retest the patient, and you see that it went right there. Like immediate post-stage CT shows that, that almost exactly you can superimpose that, matches that. And then subsequently, usually we do follow-up MRI, like they wait for 4 weeks or something like that. And you see that there is no longer that arterial enhancement, and all you see is the treated cavity. And that's what you want to see. And, you just have to rigorously apply the same criteria, use everything you got, basically. So this was a case that I saw here. And like I said, use everything you got. Like you did not have the T2, like you can ask for T2, I guess. I don't know if it will, get you anywhere. But even with these, already know it's a cirrhotic liver, so your suspicion level should be high. And then you see a nodule already, right? So there is a nodule which is mildly hyperintense. Okay? So now hemangiomas are not going to be hyperintense, typically on T1, right? You want hypointensity. And then on the this is the arterial phase. It's like just, showing up like a light bulb, and then it's washing out. I would have liked to see, we don't know at what time point they did this. Then if they did it immediately after this, we have seen this actually used to get in many cases from outside for second reads, because the transplant surgeons wanted us to read the study. It depends. If you did a portovenous phase and immediately did this, it may not be enough time for it to show the washout. So that's why we used to do 7 minutes, because I don't know if you remember, like the biliary carcinomas are supposed to retain contrast. And sometimes we can get a mixed biliary and HCC in these patients. So we used to kind of wanted to catch that also. That's how we picked the 7 minutes. Typically, most people, anywhere from 3 to 8 minutes is fine. 3 to 5 minutes is what people use. But again, there's really not washout. So if you were to categorize based on just this, seeing everything, what would you do? You probably would put it in a 4, because it's well-defined lesion. It's a nodule. You already know that from the pre-contrast. It's enhancing. I mean, that is the most sensitive part, right? The arterial phase. And it's somewhat washing out, but you would have liked to see a complete washout, which you don't. But, I mean, it's more than 1 centimeter. So, I mean, I would put it as a category 4 lesion. Okay. Now, jumping to, I mean, I just wanted to kind of incorporate the cases that I saw here. I came across also, I just saw this case yesterday for something totally unrelated. I thought it is interesting, because I have seen these being misread a lot of times, like I said, when we used to see outside cases. What do you think, like these lesions? This actually, I have no, I mean, I don't know, it still needs to be confirmed, but from what I've seen, this looks like a ring enhancing, these look like ring enhancing lesions. In a patient who is a 75-year-old, I think she had, there was colon surgery, there was evidence of colon surgery. Ring enhancing lesions are metastatic lesions. So that's something that you want to keep in mind. And you know, I may be wrong. Like I said, I don't know the follow-up on this. But whenever, be careful whenever they're ring enhancing. I've seen these being called like these could be hemangiomas or whatnot. Like, so the one thing to follow is the hemangiomas are a broken ring. They're peripheral nodular. They're not a complete. This is like, you know, if it is a complete ring, then many of the metastatic lesions, especially the mucinous ones, you know, hypodense center and ring enhancing on the periphery. So I think that's what these are. And there was one cyst, and then there were some of these. And like I said, you know, hopefully we'll get some follow-up. But that is something that you want to keep in mind, especially on CT. MR, in a way, you can treat a bit because you have the help of many other sequences. In CT, many times all you get is one case. So I've seen these being called hemangiomas there. Like, you know, when I was at Einstein, so I thought, like, when I came across this, I thought, like, and we don't need to call it indeterminate either. Like, you can say, you know, given if there is history of whatever, you know, at least prioritize. I think this is what it is, but, you know, so at least your level of suspicion, they know, instead of just saying it is indeterminate. Okay, I think this is the last case, and if you have any questions, I think I want to open the chat here. Here. Okay, any questions?
A lot of times you see this brightly enhancing lesions on whatever they usually portal phase image we get. Smaller ones, 1.3.
Yeah, what I usually call them is, especially the patient is younger and there's really no history of any suspicion of you know, cancer or malignancy. What I say is, in the absence of any known malignancy, these most likely represent flash filling angiomas done. Like, because, yeah, like you said, you know, 1 centimeter. Like, do you really want to tell them, like, you know, do an MRI like on a 20-year-old or a 30-year-old? I mean, common things being common, right? I mean, most of the time there's going to be angiomas, right? So that's how I
describe one case that few I mean, brightly enhancing more than the liver parenchyma. 2-3 of them at least in any patient.
How big were they?
Around 1.3 centimeters. 1.3 maximum or 1.3 centimeters.
And then also you see sometimes that those kind of bright spots, you know, which are ill defined, and those usually I see in patients who have some kind of liver disease. That I don't see in normal livers. So I mean, I'll have to see that. And I usually say that non-specific enhancing foci, I don't think they're much, especially less than 1 centimeter, or if they're 5 millimeters or something like that, I just bury it somewhere.
There's a question. In what situation will I have to biopsy for HCC?
Yes. Follow-up for suspicious lesions. Biopsy, nobody, they have almost completely stopped biopsying because UNOS does not. The only reason to biopsy was put the patient on the transplant list. So if they can accomplish that without biopsying, because you know it's a high risk thing to biopsy. I'll give you an example. We had an HCC patient. Usually, the metastatic workup before transplant is, you know, negative for patients who have small lesions. For larger lesions, some of them may end up having bone or lung mets, and those are the most common mets. So patient had a humeral lesion, and the image, I don't remember whether it was a CT or an MRI, I can't recall right now. It was a fairly sizable lesion in the humerus. And we said it enhanced just like an HCC. I mean, it just lit up like it was so vascular. And we said it was a metastatic HCC lesion. And I'm not sure why the orthopedic surgeon, they're not very familiar with these lesions. They decided to biopsy that. And maybe they thought maybe it was not, or maybe they were forced to biopsy because they thought if the humeral lesion is not a metastatic lesion, then the patient is transplanted. I don't recall how big the primary lesion was in the liver. So the patient started bleeding out, and they had to call the cardiothoracic and vascular surgeon. And the patient almost died on the table. So I mean that just goes to show you, and they can spontaneously. The other thing I want, the complication of HCC is they can spontaneously rupture, and patients get bleeding, like internal hemoperitoneuria. So I mean these are extremely vascular lesions. Of course, the smaller ones, it's going to be difficult to biopsy. So typically, the smaller lesions, anyway, up to 2 centimeters, we don't get points for transplant. So they just wait, and if it is 1.8 centimeters, they will say, like, can you make it 2 centimeters so they can push them off that list. So once it is 2 centimeters, you almost always are able to tell, like, which way this lesion is, whether it's just a dysplastic nodule. Nobody calls it a dysplastic nodule. And if you look at the old literature, like, there's so much description about dysplastic versus hyperplastic nodule versus, it's a continuum, right? I mean, it's a continuum. Like, it's very hard to separate those out. Like, they can do whatever they want. And so the main thing is once they start enhancing arterially, then they fall into the. And there are some in between, and maybe those are the ones that we cannot tell. So nobody uses those terminology, that kind of terminology in the radiologic description anymore. And like I said, all these things kind of we learned the hard way because there was no one. The literature was not there yet, and all this literature is only from last 5, 6, 7 years. Yeah. So, anything?